All right, everyone, let's get started. So welcome back to the Dermatology Translational Science Lecture Series. I'd first like to thank Pfizer for their generous support to enable us to have this program and, of course, bring in our wonderful speakers. And our wonderful speaker today is Dr. Suraj Venna. Oh, we got a better picture. Oh, yeah, there it is. That's much better. He's that good. He holds DNA in the palm of his hand. You got to tell me how you do
Great
that.
marketing.
Phenomenal marketing. That's PowerPoint at its best. So Dr. Venna holds many titles and contributes tremendously to the field of dermatology. And one of those roles is as a mentor and an educator. And we're very fortunate today to have one of his prodigy, Dr. Misty Alarian, who will be introducing her former mentor.
Okay, so the microphone was broken.
My bad.
But I'm introducing Dr. Venna. He's a board-certified dermatologist and director of the INOVA Melanoma and Skin Cancer Center. He's fellowship-trained in melanoma and cutaneous oncology. Prior to his position at INOVA, Dr. Venna directed and founded a multidisciplinary melanoma and skin cancer program in Washington, D.C. The melanoma team was the recipient of the President's Patient First Award. I didn't know that. Given for outstanding delivery and coordination of care. He was faculty at Georgetown University School of Medicine, where he taught medical students and trained residents in dermatology. And Dr. Venna also directed the Melanoma and Cutaneous Oncology Fellowship Program, where I was one of the fellows. Dr. Venna began his medical training in Washington, D.C., where he was an intern at Georgetown. He completed his dermatology residency training at Boston University, where he also completed an additional year as a research fellow in melanoma. Following this, he went to UCSF to pursue a fellowship in cutaneous oncology, and Dr. Venna also served as faculty at BU and UCSF, where he was director of the melanoma screening clinic. And during his time at UCSF, he was awarded Teacher of the Year consecutively in 2008 and 2009. He's actively engaged with dermatologists both on a local and national level. Dr. Venna was on the executive committee of the Washington, D.C. Dermatological Society and is also past president of the society. On a national level, he served the AAD on the State Policy Committee and Pigmented Lesions Subcommittee. In 2011, he was awarded the Presidential Citation for the AAD for his testimony at the U.S. FDA hearing to ban tanning beds. Dr. Venna has been involved with the American Society of Clinical Oncology and served a 3-year term on the Melanoma Education Committee, for which he was a track leader in his final year. I will say he has been a very prominent person in my life, and he gave me my start in dermatology, so I'm very grateful to say welcome, Dr. Venna. Thank you.
Well, that was quite an introduction. Thank you, Misty. Misty, it's great to see you here today, and Misty was really an excellent fellow, and clearly she's evolving into a great dermatology resident. So I'm going to talk to you today about some of the advances in melanoma. So over the last 10 years, there's been significant advances in treating melanoma, and so we're going to. So first, I have no disclosures that are relevant to this talk. And just to get you to start thinking about melanoma, I knew there'd be mostly residents here. We're going to run through 2 minutes these 4 pre-test questions. So I'll read them out loud. So among the Braf mutations observed in melanoma, over 90% are at codon 600, and among these, 90% are a single nucleotide mutation. What is the most common Braf mutation in melanoma? V600D, E, K, or F? Question 2. Ipilimumab is a monoclonal antibody FDA approved for advanced melanoma and also in the adjuvant setting. What does Ipilimumab bind to? CTLA4, PD1, PDL1, or CD28 on activated T cells? Okay. TVEC is an intralesional oncolytic viral therapy for melanoma. It is a modified herpes simplex virus. Which of the following are true? It is a genetically engineered strain of HSV1, B, HSV2. It can secrete GM-CSF. It has deleted ICP 47 and 34.5. all answers are true except B, or all answers are true except A. Okay. The last question, pembrolizumab is an immune checkpoint inhibitor that binds to CTLA-4, PD-1, PD-L1, or CD28 unactivated T cells. So I selected these questions because I think these will be the kind of basic science questions that you all should be familiar with in terms of mechanisms, and we'll go through all this. So for today's talk, my objectives are to review broadly the mechanisms of treating patients with melanoma. We're going to talk about targeted therapy, immunotherapy. I'm then going to show you a few cases of how these drugs have been able to provide patients with a significant disease-free interval from their melanoma. And also hope to demonstrate the value that we all have as dermatologists, even once your patient develops advanced disease. And then we'll end with a few slides on evolving concepts about the tumor microenvironment and how that is now being classified in melanoma. So, ABC News Flash, November 2007. Botox may beat cancer concern in race to dermatologist. Wait time shorter for patients seeking wrinkle injection than those with suspicious moles. So 900 dermatology offices were contacted, and they were given a question. So I want Botox, 8 days to get in. But I have a changing mole, 26 days to get in. So in that short period of time, a nodular melanoma can develop, a deadly vertical growth phase. And so it's very important that we train our staff and that you all do your best to see patients as quickly as you can. Now, I put this slide in because I was challenged by our oncologist to see how I could meld Botox into a melanoma talk. So you can tell them that I tried. All right. So to get you to start thinking about advanced melanoma, here's a quick case. This is can we maybe turn this light down a little bit? So this is a 77-year-old woman. She had a 3.5 millimeter nodular melanoma on the scalp. She had a staging CT, which was unremarkable. Wide excision showed a residual 4.5 millimeter melanoma. So she was a pathologic stage B, which has a 70% 5-year overall survival. So at an 18-month post-op visit, the clinical exam was unremarkable. The primary site was well healed. But I always see these patients with the medical oncologist. So he did a routine surveillance CT, which unfortunately demonstrated 2 large foci of metastatic melanoma in the lung. Asymptomatic patient, though, otherwise. So what are the next steps for this otherwise healthy 78-year-old who takes her grandkids to swim class and drives and all that? Do you consult thoracic oncology, radiation oncology, hospice, or do you start to think about a systemic immunotherapy? So given the name of the talk here, you know the answer. So she was started on a checkpoint inhibitor called pembrolizumab. And after her 12th dose, she had complete radiographic resolution of her melanoma with minimal side effects. So I just wanted to start with this case as an example of many patients today who are really having great, amazing responses to these new therapies. This is sort of summarizing all of the FDA-approved treatments for melanoma. So in a very short time, we have 15 approvals all of a sudden. So in the advanced setting, we can break them down into targeted therapies, which we'll talk about, combination targeted, systemic immunotherapies, combination systemic, as well as intralesional therapies. Now the success of these drugs in the advanced setting are now being moved into the adjuvant setting, which means to try to prevent the recurrence of melanoma. These are the broad approaches when you look at targeted versus immunotherapy. In targeted therapy, small molecule inhibitors have been designed that specifically and potently bind to mutated kinase in a significant number of melanomas. So targeted therapy is targeting the tumor up front. This is in contrast to immunotherapy, which up front anyways is trying to actually target the patient's T cells and promote T cell activation, and these are called the checkpoint inhibitors, and we'll talk about these monoclonal antibodies shortly. And it's worth mentioning the dynamics of the clinical response. So in targeted therapy, the tumors tend to regress quickly, so a lot of patients tend to have a shrinkage of their tumors. But as you can see here, the red is the control, almost every patient will have progression of their disease. This is in contrast to immunotherapy, where up front, a lot of patients are dying. However, there are a subset of patients at about the 2-year mark who seem to have a benefit from immunotherapy. It's about 20% of patients at 2 years out are living. And this is called the tail of the curve phenomenon in immunotherapy. So there's often a delayed response in this small subgroup of patients. So first, let's talk about targeted therapies. So one of the most compelling examples in cancer biology is the development of BRAF inhibitors in the treatment of advanced BRAF-positive mutated melanoma. And one of the key drivers in melanoma is the MAP kinase pathway. And in that pathway, about 50% of melanomas have mutations in the BRAF kinase. And so this is the MAP kinase pathway where you have RAS, RAF, MEK, ERK, and that leads to cell signaling and cell growth. So the first BRAF inhibitor that was approved was Venna, and it targets the V600E codon. Shortly thereafter, another company developed their own BRAF inhibitor, and that's called Dabrafenib, which actually targets V600E, K, and D. And so in the key phase 3 trials where they tested these drugs, on average, the response rate was about 50%. But the issue is that the median progression-free survival was only 5 to 6 months, which means that after that point, most patients have progression or recurrence of their disease. Now, the BRIM-3 trial, this was a phase 3 trial which compared Venna to chemotherapy or dacarbazine, and this is back in 2011. So it established that a BRAF inhibitor was superior to chemotherapy, and the overall survival advantage was 13.6 months versus 9.7 months. Doesn't sound like much, but this is 2011. We're talking about melanoma. So this is really the first case where the, quote, genetics of melanoma was targeted and actually shown to improve survival in patients with advanced disease. So there's still a lot of excitement about Venna at that time. And this is a phase 3 trial comparing the other BRAF inhibitor, Dabrafenib, versus chemotherapy. Their primary endpoint was showing an advantage in progression-free survival. So they demonstrated that the BRAF group, they had 5.1 months of progression-free survival versus 2.7 in the chemo group. And this is a graph called a waterfall plot that oncologists are very familiar with, but each bar represents a patient, and a bar that's going down represents tumor shrinkage. So it's just to demonstrate that, again, up front, most patients on BRAF inhibitors will have some degree of shrinkage of their tumor. So here's a woman with an unresectable melanoma of the breast, and this is just 5 days on an oral BRAF inhibitor, and you start to see this necrosis. So now with the success of the BRAF inhibitors, various resistance mechanisms were being unearthed, and one of them is the mutation in MEK, which is downstream of BRAF. And so pharma decided to target MEK. So Trametinib is a first-in-class oral MEK inhibitor. So with the BRAF inhibitors, the response rate was about 50%. With Trametinib, or the MEK inhibitor, it was only about 22%. And this also suffered from the same issue of progression of disease at about 5-6 months. And this is the key phase 3 trial that demonstrated Trametinib, MEK inhibitor, superiority to chemotherapy. And it demonstrated both progression-free survival versus chemo, as well as an overall survival versus chemotherapy. Now the BRAF inhibitors have this somewhat peculiar side effect of patients developing cutaneous squamous cell carcinomas. And the thinking is that when you have a patient who has a BRAF mutant melanoma, and when they receive a BRAF inhibitor, these patients likely have pre-existing RAS mutations in their keratinocytes. So when they start taking a BRAF inhibitor, it's thought that there is a paradoxical activation of another RAF protein called a CRAF. And then that leads then to upregulation of ERK signaling in the MAP kinase pathway. So this is the mechanism of how we think there's this paradoxical growth of skin cancers in patients on BRAF inhibitors. So now we've talked about BRAF inhibitors, 50% response rate, MEK inhibitors, 20%. So the thinking was, well, what if we combine these two? Can we improve on that? And indeed, when you combine a BRAF and a MEK inhibitor, the response rate is now 65 to 75%. And these are the approved combinations, so Vemurafenib with Cobimetinib and Dabrafenib with Trametinib. So not only was the response rate improved, but the median progression-free survival now was doubled. And these are the three key trials that established the superiority of combining BRAF and MEK versus BRAF alone. And it just shows, a better response rate and a better overall survival when you combine these drugs. Now, usually when you combine medications, side effects typically go up, adverse events. But in the case of combining a BRAF with a MEK, because you have this dual inhibition, the rate of squamous cell carcinoma goes down to almost zero because you're doing the dual blocking of the MAP kinase pathway. So here's a patient who initially had a 3 millimeter ulcerated primary on his temple, and then 5 months later presented with this indurated plaque on the right preauricular skin. There's some papules here. And then, of course, it kind of extended into the right temple area back where he had his primary. So he was found to have a V600K mutation. So based on that, he was started on Dabrafenib with Trametinib because Vemurafenib only targets V600E. So after 2 weeks, there's not much difference. But at 4 weeks now, I think you can appreciate some regression here and necrosis of this nodule. And then at 6 weeks, there's nice regression of his unresectable melanoma. So prior to this, we frankly didn't have good options for this kind of patient. I mean, we could try interleukin-2, you could try radiation, and then maybe a very aggressive surgical oncologist may try to resect the whole area, but that really wouldn't help this patient because he's at risk for systemic disease. So knowing that these patients end up progressing, well, what do you do next after this guy? You've kind of bridged him now for a few weeks. And that takes us now to the immune checkpoint inhibitors. And so what are immune checkpoints? So immune checkpoints are regulatory signals that allow for immune homeostasis, allow for the prevention of autoimmunity, and try to really control inflammation so that you're not in a pro-inflammatory state all the time. And so T cells express co-inhibitory molecules on their surface, and the two that we're going to talk about are CTLA-4 and PD-1. Now, as it turns out, melanoma and other solid tumors have the ability to hijack these sort of checkpoints on the T cells. But fortunately, these monoclonal antibodies, as I'll show you, can overcome tumor-induced T cell inhibition. So in order to understand how Ipilimumab works, we have to spend a minute talking about how to activate a T cell. So here's the melanoma. There's antigen. Dendritic cell picks up the antigen, presents it to a T cell, and then the first interaction is MHC presenting antigen to the T cell receptor. And then the accelerator, if you will, is the second signal of the binding of B7 to CD28 on the T cell. Once that happens, you have an, quote, activated T cell. Once that happens, CTLA-4 from within the T cell migrates to the synapse. And CTLA-4 has a much higher binding affinity for B7 than CD28. So when that happens, now the T cell becomes, quote, inactivated. So the way that Ipilimumab works is that it binds CTLA-4, disrupts this interaction, releases the brake, if you will, and then allows for that T cell to remain activated. And so Ipilimumab, the key studies were done a few years ago, but it only showed a response rate of about 10%. But as I showed you in the beginning, when you look at dynamics here, the 2-year overall survival, though, was 20 to 25%. So there's still this subset of patients who are benefiting from Ipilimumab. This is the key phase 3 trial comparing Ipilimumab versus vaccine versus Ipi plus the vaccine. And basically what it demonstrated is that regardless of the vaccine, the Ipi groups afforded patients a better overall survival. So now if you look at all of the data from the last 10 plus years of Ipilimumab for melanoma, this pooled analysis was done from 12 studies with about 1,900 patients, again, nicely demonstrating this tail of the curve phenomenon at 10 years. So at the 3-year mark, if you're living and you have advanced melanoma, there's a good chance you might be actually cured from your disease. So oncologists, they don't like the 4-letter word cure, right? But they've designed this term called curative potential. Yeah, so they're never going to tell the patient that you're cured from melanoma, but I think we have very good evidence now that there's a possibility, if you have stage 4 melanoma and you're 3 years out, that you actually may have overcome the melanoma. And this is just a brief slide on some of the side effects of CTLA-4. Very common is just a macular papular eruption, very similar to what you see with antibiotic eruptions, and it's managed with topical steroids. But the one that is really the most inconvenient, if you will, for patients and irreversible are the endocrinopathies. So patients that develop hypophysitis, thyroiditis, adrenal insufficiency, and then the one that's really the most debilitating, well, in terms of dermatology, or development of TEN or SJS, but although I've never seen that yet. So far we've talked about CTLA-4, and when we think of the role of the immune system in cancer, you can think of it as a peripheral immune system, meaning lymphoid tissue and lymph nodes, right? And then also think of the tumor microenvironment here, meaning once you get to the melanoma or to the tumor. So CTLA-4, Ipilimumab, is working again by releasing the brake and allowing for activation of your T cells, and this is happening in your lymph nodes. But now, once you have an activated T cell, that's just half the battle. You now have to migrate into the tumor microenvironment, and then there have to be strategies to overcome the tumor's inhibition of an activated T cell. Okay? So now we're going to talk about pembrolizumab and nivolumab. So, right. So, well, let's see. Sorry. Okay. So the activated T cell here gets to the melanoma. But the melanoma expresses a ligand for PD-1. So this interaction shuts down the T cell. And PD-1 belongs to the same receptor family as CD28 and CTLA-4. And so these medications bind to PD-1, pembrolizumab and nivolumab, and disrupt this interaction so that the T cell can then remain activated and produce interferons. So as it turns out, in the tumor microenvironment, when the T cell produces gamma interferon, that leads to an increased production of PD-L1 by the melanoma. So that's called adaptive immune resistance. But fortunately, because of these medications, we can take advantage of that PD-1, PD-L1 axis by disrupting that interaction. So these drugs have shown a response rate of about 30 to 40%, so better than or higher than Ipilimumab. 1-year overall survival of 75%. Keynote 006 is the key phase 3 trial, which compared pembrolizumab to the standard at the time of this, which was Ipilimumab, and demonstrated at 33 months a 50% 33-month survival versus 39% in the Ipi group. So this phase 3 study really established anti-PD-1 or pembrolizumab as the standard for advanced melanoma at that time. So there are many different drug companies that are competing to develop these. So a different company developed nivolumab, which is another anti-PD-1 drug. So this is the key phase 3 trial comparing nivolumab to chemotherapy, which demonstrated a 1-year OS of 73% versus 42% in the chemotherapy group. So this study led to its approval as another stage 4 melanoma treatment. And so with the PD-1 drugs, the side effect profile is very similar. And again, the most debilitating in these patients are the endocrinopathies because they're irreversible. All right. So we talked about Ipi, 20% response rate. The PD-1 drugs were at about 30% response rate. So thinking was, can we combine these and improve on that? And the answer is yes. So there was a key study that was done in 2015 which combined two systemic IV immunotherapies, nivolumab and ipilimumab, and this resulted in a 60% response rate. So here, you're attacking the tumor both in the peripheral immunity, right, with the ipilimumab, and also in the tumor microenvironment with the anti-PD-1 drug. And this is the phase 3 data comparing Ipi plus Nivo versus Nivo alone versus Ipi. And the progression-free survival at 3 years was 39% in the combination group versus 10% in the Ipi alone group. And then for overall survival, which is really what we care about at the end of the day for the patient, is, are they going to live longer? The combination yielded an unprecedented nearly 60% 3-year survival. But the problem is that in spite of that very high response rate, 40% of patients had to discontinue this combination therapy due to high-grade side effects from this. So currently, one of the strategies in developing clinical trials is how do we get to at least a 60% response rate or higher, but decrease the rate of side effects so patients can actually tolerate these medications. So one of the strategies is trying to combine one of these drugs with, for example, an intratumoral medication. So telimagene lahervapec, or TVEC, is a first-in-class intralesional oncolytic immunotherapy approved by the FDA for melanoma. So it's approved for patients with stage 3 and 4 disease who have an injectable lesion. Now, that could be a skin lesion. It could be a lesion that you can detect with ultrasound and actually hit. And it is a modified HSV1 virus. It was derived from a fever blister. It's called the JS1 strain. And I think this is just a remarkable example of translational medicine that the virologists have done. So they've modified this HSV virus to delete its neurovirulence factors. So there's a deletion of ICP 34.5 and 47. So ICP is for infected cell protein. So 34.5, its normal function is that when HSV infects a keratinocyte, it allows for replication. But so when you delete it, this modified HSV cannot replicate in healthy keratinocytes. But in the microenvironment of a cancer, because there's uncontrolled growth, the virus can still replicate. And then the function of 47 is to allow for, the function of 47 is to inhibit antigen presentation. So if you delete it, it will allow for antigen presentation and to enhance the immune response. And so with all of this, you get tumor lysis and you get increased antigen presentation. The Optim trial, this phase 3 trial, compared TVEC to subcutaneous GM-CSF and demonstrated a marginal overall survival advantage, 23 months versus 19 months at about 5 years out. And so in this study, they did achieve their primary endpoint, which was to demonstrate an improved durable response rate. But what was interesting is that 2/3 of injected lesions had an initial response, but also 1/3 of non-visceral, non-injected lesions also had a response. So if a patient had a nodule in the left arm, in some of them, the lymph node in the right arm actually started to shrink. And then 15% of visceral sites regressed, at least radiographically. So this suggests that when you inject a lesion on the skin, you can induce a systemic immune response. So this is how it works. So you inject the melanoma, and when you inject it, you are also going to cause tumor lysis. When the tumor breaks, you're going to have the release of tumor-derived antigens. And so these antigens are then taken up by the dendritic cell and lead to activation of a T cell, and then that T cell has to get to the melanoma microenvironment. Let's see. So keeping all of these 3 medications in mind, ipilimumab, the PD-1 drugs, and TVEC, I want to briefly review what's known as the cancer immunity cycle. So cancer immunity can be divided into 7 steps. So you start with so here's the melanoma. You start with the release of cancer antigens, which are presented to APC's dendritic cells, which are then expanded in the lymph node, which then traffic into the bloodstream and then eventually into the tissue, are recognized by T cells and then lead to cancer destruction. So keeping this immunity cycle in mind, we can add some of these immunotherapies. So TVEC, when you inject, is going to release tumor-derived antigens. You're going to have more antigen-presenting cells. Ipi is going to work in your peripheral immune system to allow for continued activation of these T cells which have picked up the antigen. And then once those T cells get to the tumor, you can now disrupt the tumor-induced inhibition of this activated T cell. And this is a summary slide just showing the overall trends of many of these recent trials for advanced melanoma, and clearly the bar keeps, getting elevated, which is what we want, but there's still more room for this, for patients to have a better long-term outcome. So let me now move on to just a few cases. So this is a 58-year-old. He had initially a stage 1B melanoma of his left eyebrow, and then 7 years later presented with this parotid mass. FNA was positive for recurrent melanoma. Here's an MRI of his face, and as you can see here, he has this, like 5-centimeter mass. Look at all these matted nodes. See these? So what do you do for this guy? You do surgery? So he was deemed unresectable, and he has stage 3C melanoma, which has a 75% risk of recurrence and death. He was BRAF wild type. So we reviewed different immunotherapy options for him. So anti-PD-1 therapy, Ipilimumab, or combination. So he started pembrolizumab monotherapy, and he had a complete response in 6 months. No evidence of residual disease. And the other thing we noticed is that he had multiple non-melanoma skin cancers on his face. So this is time 0, 6 months. And we didn't biopsy it. Just with dermoscopy, we were confident it was a basal cell. So you can see in this time that the lesion clearly was regressing. And here are some other lesions on the face that also over that 6 months also appeared to be shrinking. He also had 2 pigmented lesions. And so this is time 0, this is time 6 months. And so because he had metastatic, he had locally advanced disease, we told him when we saw him that I was worried that this might represent melanoma, but what was the point right now since he's on the pembrolizumab? But once he had regression, then we decided that we better take these off. So I excised this, and it was a lentigo maligna, but with a very prominent lymphocytic host response. I mean, clearly we can see a TIL response in lentigo malignas, but this is a bit more than a typical LM. And I don't know, Dr. Glass, can you, a couple of comments? Yeah. Right, so more than your average lentigo maligna. Now on his chest, he had this pigmented lesion. Again, over the 6-month period, it was actually starting to clinically regress. That's a dermoscopic image. So then I excised this, and this was a 0.36 millimeter non-ulcerated, non-mitogenic melanoma, but with a really brisk host response. So we believe that this really brisk host response is because we did this after he had completed anti-PD-1 therapy. And one of an evolving concept in trying to predict who might respond to these various immunotherapies is the tumor mutation burden. So it's the somatic mutations can be measured from the tumor specimen, and the higher the mutational load, the greater the chance of producing neoantigens, which can then be used to stimulate an immune response. So the blue bars represent mutations that are largely with UV signatures, and the red bars are non-UV. So as it turns out, basal cell has a very high mutation burden, somatic mutations, followed by squamous cell, followed by polyomavirus negative Merkel. There's cutaneous melanoma, CTCL, apomelanoma, and then Merkel cell positive, virus positive Merkel cell. So there are currently trials that are underway to look at the role of PD-1 drugs for advanced squamous cell And earlier this year, we already had approval of an anti-PD-L1 drug for Merkel cell carcinoma. Okay, let's go on to case 2. So this is a 30-year-old woman. She had a new dark irregular mole on the thigh. Saw her dermatologist, and the patient wanted it off, but the dermatologist said at that time it looked benign. Came back 3 months later, had a biopsy. It was 1.1 millimeters, non-ulcerated, mitotic grade of 2, with a non-brisk host response. Wide excision, negative sentinel node, stage 1B, 5-year overall survival, 90%. And let me just say to the residents, you know, I think when a patient has a gut feeling about something, just take the mole off. All right. So unfortunately, 18 months later, she had a nodal in-basin recurrence right here and right here. And, you know, again, this is a young, otherwise healthy woman, just got married, trying to start her life. So what do you recommend for this young person? Surgery, radiation, immunotherapy combined, immunotherapy monotherapy, or a targeted approach with Braf and MEK inhibitor? So does anyone want to guess what you would do in this young, healthy person? Any suggestions? There's actually no wrong answer. So what we ended up doing was we put her on the best available therapy, which was a combination of Ipi and Nivo. So here's what happened. So after her first infusion, she developed pancreatitis, so it had to be discontinued. But in the meantime, her BRAF status came back, and she was V600E positive. So then she was started on Vemurafenib and Cobimetinib, but that was discontinued due to the development of DRESS. Once she overcame that, we put her on Dabrafenib and Trametinib for 4 months, and she had a complete response. And then she was migrated to Pembrolizumab as maintenance. 2 months later, she calls us saying, I feel a golf ball-sized lump in my groin again. So you can see it lit up here on the PET. There it is. So now what do we do? Do you do surgery? Do you do radiation? Do you discontinue the Pembrolizumab? Or do you think about a neoadjuvant approach where you could try and shrink this and then do surgery? So, Dr. Glass, you're right. That's what we did. No, so we did it. So she was given a neoadjuvant treatment. And I don't know if the residents how familiar are with that, but basically it means a treatment before something else. So here we're trying to shrink the tumor followed by surgery. So what was fascinating is that she had a rapid clinical response. 2 weeks, this thing was melted away. And then she had a superficial groin dissection. There was no melanoma. All the markers, I'm not showing you this for the sake of time, but all the markers were negative. So there was no histologic evidence of melanoma. So at that point, she was restarted on her Pembro. But then 3 months later, developed this soft tissue mass in the left anterior thigh, all in that same area. So because it was a solitary lesion, that was excised by the surgical oncologist. And this time we saw this really brisk host response again with a lot of tumor necrosis. So she was developing some kind of immune response even though she developed this local recurrence. So then she went back on the Pembro. And my comment on this case is that, you know, the dermatologists, we're the best at picking up melanoma early, but when your patient develops recurrent advanced disease, that's when they need us more than ever. I mean, you know, the oncologists are the ones doing all this treatment, but, you know, giving them a phone call, checking in on them, being there to support the oncologist. So when the patient develops DRESS or some other side effect from these drugs, you know, we're there, you know, for the patient. And the second thing is that this is an example of sort of the roller coaster that patients with advanced melanoma today are experiencing. So on the one hand, it's great that we have all these options. But on the other hand, you know, we still don't have a great hold on who are going to really respond well to these drugs. So this is the last case. Do we have about 10 minutes? Yeah. Are we good? Okay. So this is a 58-year-old male. He had a 3 millimeter melanoma of the scalp. And this is him before surgery. Let's see. So he had a wide excision and a negative node, stage 2A melanoma. 5 months on routine exam, though, he was noted to have multiple scalp in transits. So this is again showing why the dermatologists, we gotta be there with the patients, because we're the ones who are going to find this. The oncologists, I don't think they're going to biopsy or touch this. So he was started on pembrolizumab, and this is him at 3 months, 6 months, and 9 months. So good, right? He's had complete regression. Things are looking great. But then there's always a but. This is why we're so valuable, the dermatologists. But basically, on his left anterior thigh, so his melanoma was here, but on his thigh, he had this new brown papule, and we do total body imaging. It was just new, but it didn't look like much with dermoscopy. But I punched it, and it was melanoma. So it was a cutaneous metastasis of melanoma on his thigh. And he just had a PET CT scan. So the oncologist walks out saying, hey, everything looks great. And then we find this. And it is really hard to sometimes tell necrosis from TILs, but in this case, there's no necrosis, and it's all just mostly TILs and a lot of lymphocytes. And so that was excised. And then 7 months later, within the scar, he developed another solitary cutaneous metastasis. And again, he just had a normal whole body PET. Scalp was looking great. And this time when we biopsied it, there were no tumor infiltrating lymphocytes. So something's happening here, right? The tumor's hot, then it's cold. And after that, it was decided to restart him on pembrolizumab. So he's been NED or no evidence of disease since that time. So what's happening in this patient, right? So currently in immunology and cancer, there's this new paradigm of trying to classify cancers based on their tumor microenvironment. And I'll run through these. So the type 1 cancer, so basically they're breaking down cancers into type 1 tumor microenvironment, 2, 3, and 4. So a type 1 cancer or tumor is thought to be a hot tumor. So a hot tumor expresses CD8 positive cells, and the melanoma expresses PD-L1 ligand. And as I told you earlier, an activated T cell increases gamma interferon, which increases PD-L1 expression by the melanoma on its surface. So now these patients, we can target them with pembrolizumab, right? So of these different subgroups, the type 1 or the hot tumor, this group has the best prognosis in melanoma. So these hot tumors, this is in contrast to, quote, cold tumors, which don't have any TILs, and the melanoma is not expressing PDL ligand. This makes up about 41% of melanomas. And this is also known as an ignorant tumor, immunologically ignorant melanoma. Type 3 tumors have no TILs, but yet the tumor expresses PD-L1. And this is known as intrinsic induction. So rather than interferon gamma stimulating upregulation of the tumor to make PD-L1, the melanoma itself is making PD-L1 on its surface, or expressing PD-L1, I mean. And then the fourth group is called the tolerant tumor microenvironment of cancer, which are TIL positive, PD-L1 negative. And in these cases, there's some other inhibitory pathway at work. So for example, many tumors, including melanoma, breast, ovarian, overexpress IDO, or indoleamine 2,3 dioxygenase. So there are studies trying to combine pembrolizumab with an IDO inhibitor. So in terms of future directions, I mean, I think it's clear that while we will use the BRAF and the MEK inhibitors, the focal point, at least at this point in time, are really the checkpoint inhibitors, both CTLA-4 and the anti-PD-1 drugs. And some of the strategies involve trying to combine these with other immunologic treatments to, again, try and decrease the side effect profile, but continue to push that bar of overall survival. And so there is an ongoing trial of pembrolizumab with TVEC, for example. There are some proposals to combine systemic therapy with radiation, so radiation causing tumor death and release of tumor-derived antigens. And then also systemic pembrolizumab with various inhibitors, such as an IDO inhibitor. So the goal is, can we prevent hot tumors, so the type 1 tumor and microenvironment from cooling off? And also, how can we make cold tumors hot? So in the last two cases that I showed you of the guy with the scalp and that woman, so they've just been cycling through all of this. And so it's still going to take years of trying to figure out the best predictive markers and how to really enhance the immune response. And lastly, I was a first-year medical student in 1996, and I think immunology was 2 days. I don't know. But there's a group called the Society for Immunotherapy of Cancer, or SITC, and this year the meeting's in DC in November, and they actually have a 2-day boot camp that I'm going to that's going to basically review all of the basic immunology, and I think it's going to be a great opportunity for anyone in here to check out. That's it.
Do you have any questions?
What happened with Carter, with President Carter?
Oh, Carter, yeah, so he presented in, that's a good one, because patients like, oh, Dr. Jimmy Carter. But he presented in 2015 with melanoma unknown primary, so brain, lung, liver. And he actually got pembrolizumab, the anti-PD-1. So he's been in remission since then. And the only thing we didn't get to today for the sake of time is really that, is the fact that these drugs, they're effective in like maybe 30% of the overall cohort of melanoma patients with advanced disease. So there's still a huge unmet need in 70%. And then, we're not even going to talk about the cost today of these medications, but they're expensive.
Well, is there an access issue? Is it hard to get these covered when they come to you at INOVA?
No. We also have compassionate use programs, patient assistance. Yeah.
Kind of along the lines of the TVAC, in terms of ECT, in combination with systemic therapy, what do you think about that?
ECT?
Uh-huh.
As in?
Like electrocute therapy?
Oh, I'm not very familiar with ECT for melanoma. Yeah. But it would probably be the same idea of causing tumor death and release of antigens, right?
Yeah.
Yeah. Mm-hmm.
I know that you mentioned vitiligo is one of the kind of side effects of the immunotherapies, and do you see that more commonly in people who have more extensive sun damage?
Not necessarily. We actually first saw vitiligo in the early interferon trials for melanoma. And so the development of vitiligo or psoriasis, or an autoimmune reaction, is actually associated with a better response and prognosis. But yeah, it's not correlated with photo damage. Yeah?
In your experience, have the papers distinguish between age and response to immunotherapy for young people more likely to respond, or is it really not better?
Yeah, so it seems that younger patients actually do respond better to immunotherapy. And it's really because of the fact that they have a more competent immune system to begin with, we think.
Does it make sense to combine MAP kinase and checkpoints? I mean, is that just going to produce so much side effect? Basically, you could slow the growth, increase.
Yeah, so there are some ongoing discussions about could you combine a BRAF inhibitor with pembro, but right now they're really being used in sequence based on the tumor burden that the patient is presenting with. So if someone has widespread melanoma that's progressing quickly and they have a BRAF mutation and they go on BRAF MEC for a few weeks, to just slow down this out of control train, and then they're converted
So you're
into
doing subsequent, once you get the idea that it's BRAF positive, you go with those agents first.
if they have a high tumor burden, right?
Yeah, high tumor.
Right.
We had at Moffitt when BRAF inhibitors first came out, the side effects were really severe. I mean, they not only got squamous cancers, but they also developed this colloidal eruption and small wart-looking papillomas, widespread. I don't know if you've seen it, but you may have come on when they already had combination therapy with the MEK agent. But that changed the atmosphere completely once MEK inhibitors were introduced, because the side effects were really severe. And to watch it as a dermatologist, watch these patients develop disease.
Right. And we didn't know what was going on. Why are they getting squamous cell and they're on BRAF? It was like early on, we didn't really know the mechanism. So.
Right. And then to see them develop second melanomas, like you said, it really struck me, because we watched these melanomas grow, because they would have second, third melanomas, but they're being treated. And And the idea from the trial is that you weren't allowed to treat them with a melanoma. And just to watch melanomas develop.
Right.
You know, it's really interesting with the Dabrafenib and the squamous cells. When they go off of the drug, they melt away. And, you know, so we've had several patients who come in just covered, and they go off drug and they're gone. You know, even histologically, you biopsy the same site and they're absolutely gone. So clearly the drug's pushing it forward. Do you follow those patients? Let's say they go off drug, they go away. Do you still follow those patients in terms of doing repeat serial biopsies to make sure they're all gone, or in your experience, they typically do just go away?
Yeah, they typically just they don't. Yeah, they go away once they're off the drug. Yeah. And then I think, you know, just for the residents again, I was kind of joked in the beginning about the Botox slide, but I really think it's true that, you know, when you're in practice, especially the third years, when you're out there, make sure you train your staff well to get these patients in. I mean, we are the best at finding melanoma. Study after study after study shows that dermatologists are the best at catching these things early. So if you catch it early for your patient, they don't have to get any of this, right? So just keep that in mind.
Thank you.